Hey guys, it's Dr. Daniel Choi, orthopedic spine surgeon in Long Island, New York. Welcome back to my channel. I am going to be doing another reaction video today on The Good Doctor. It came highly requested. Lots of you said this was the most awesome doctor show out there, so I'm super excited to do this. It's my first ever time watching The Good Doctor, and we're gonna get started right after this. All right, guys, let's get started.
It's very big.
Yes, it is.
Renal angiomyolipoma?
You see an extensive blood supply?
I wish I could do that.
Maybe some kind of neurogenic tumor or maybe a lymphoma.
She has a sarcoma, a malignant tumor.
A sarcoma. So, obviously, Shaun here is very gifted. I wish I could just have photographic memory. Some people might have it. I definitely don't. I have to study very hard and read lots and lots of books to kind of absorb the necessary information. I can't compute things like him. What's a sarcoma? So a sarcoma is a very rare tumor. It arises from bone or soft tissues in our bodies, and there's lots of different sources that it can come from. It can come from muscle, from fat, from blood vessels, from tendons, and it's pretty rare. It's extremely rare. There's over 70 different kinds of sarcomas. I have a list here for you guys. It's angiosarcoma, chondrosarcoma, Ewing sarcoma, Kaposi sarcomas, I don't know if I pronounced that right actually, leiomyosarcoma, liposarcoma, osteosarcoma, rhabdomyosarcoma. I mean, there's a ton of them out there. And at some point, actually in orthopedic residency, we actually had a rotation for orthopedic oncology where we actually resected these tumors from the extremities. I had to know between the different types, and that's been a long time, so I don't really recall all the different types and all the distinguishing features. And if I need to know about it today, I would just look it up. I'm focused on the spine. I don't encounter this nearly as much as an orthopedic oncologist.
Does she have a malignant sarcoma? Are we going to be doing a laparotomy? We need intraoperative staging with a biopsy, extensive dissection of the retroperitoneum, and excision of the mass with wide, clear margins. I went in.
You do know you're drooling, right? About cutting open a 40-year-old woman, real person right behind that door.
So he's drooling over cutting someone open. That's kind of morbid to say. And this type of excitement amongst surgeons about a very interesting and complex case is actually pretty realistic. So it's not that he's sitting there thinking about the pain he's causing the patient. Surgeons, we have our bread and butter cases. For a general surgeon, it might be an appendectomy, like taking the appendix out, or doing a gallbladder removal. That's a very routine case. Here, he's talking about a very complex case, removing a sarcoma from a very deep part of the body. He is very excited about it. And really, I think that one of the things this brings me back to is when people ask me, wow, how do you get used to cutting someone open? Like, isn't that crazy that you're actually taking a knife and you're cutting the skin and you're seeing blood everywhere? When you do surgery, surgeons tend to kind of depersonalize the patient. You're not thinking about, oh, this patient is feeling this or is experiencing the surgery right now. What you're really strictly thinking of is anatomy. So that's why in surgery you see surgeons doing the draping, and we isolate just the area where we're working, and really all this becomes then is an anatomic challenge where we're going in, we're manipulating anatomy, and we're getting down to what needs to be removed or what needs to be fixed. And this type of excitement amongst the surgeon is actually not rare. And when something gets a little more complicated or more complex, you can often see surgeons get excited about the case.
Prep surgical team.
Sir, what do I do?
Scut work.
What's gut work?
Today I'm going to need my surgeons to have no distractions. So I need you to handle those distractions. All the work they do every day that they hate doing, you're handling it for them.
Scut work. The good old scut work. So scut work is a term thrown around in surgical training or medical training in general, and I talked about it briefly in my other video for Grey's Anatomy, where it's work that nobody really wants to do. And Dr. Melendez kind of clarified that everyone wants to operate, right? When they're in surgical training, they want to be in the OR doing cases, but that's just part of the picture. Operating is literally just like a small sliver of the entire care process for a surgery. So after surgery, patients need their vitals checked, their labs checked. You need to follow up on imaging studies, like if someone orders a CAT scan or an MRI, what was the result of that CAT scan or MRI? Someone needs to be doing that, right? In an academic setting where these interns and residents are training, all of those kind of, I guess, lesser roles or lesser tasks are assigned to the intern, like Shaun here. And it's actually just as important. So just because you're not in the operating room doesn't mean that checking vitals and checking labs is not important. That's super important. You have to learn when a lab value is abnormal, and you have to learn when a vital sign is abnormal. And this is also a chance for a intern or a medical student to show how reliable they are and how accurate they can be. And so it's a super important part of the entire care process.
Am I being punished for something?
No.
Okay.
So that's it? You just accept my answer at face value? Why?
You're very arrogant. Arrogant people don't think they need to lie. So you must be doing this to teach me. I look forward to learning from scut work.
Shaun's response there is awesome. And in many ways, he's right there. So Dr. Melendez is assigning him scut work here, just like I mentioned, to see and check how reliable Shaun is.
I'm Dr. Claire Brown. I'm first assist today, and I'll be leading the timeout. Patient's name?
Stephanie Willis.
Scheduled surgery?
Excision of an indeterminate retroperitoneal tumor.
We don't anticipate any complications with the surgery.
Thank you, Dr. Brown. 10 blade.
What they did here is something called a surgical timeout. And this is actually a super important part of the surgery. It's where the whole team, after the patient's prepped and draped and the surgery is ready to start, everyone pauses. This is a process that's been implemented widely across the world to increase surgical safety. So what is a surgical timeout? So first, it has to include identifying the patient, what the operation is, the site of the surgery. And so in spine surgery, the site of surgery that we usually talk about is the different levels. So if we're working in the lumbar spine and I may be doing a lumbar fusion at one level, L5S1, we make sure to identify that level first. There's other things that can be checked too as well to make sure that antibiotics are in before the incision's made. We also check to make sure that all necessary implants are there in the operating room. So if you're putting in screws and rods, are the appropriate implants in the room. You don't want to get to that point in the surgery and look around and be like, wait, the implants aren't in the room anymore. That would be a complete disaster. And so this is where the surgical timeout is super important. Before you start the surgery, is everything set up in the room, and everyone in the room has to participate. Turn off all the music, and I lead the timeout, and we go around the room and we make sure that everyone is on the same page before the surgery starts.
No,
It might be infected.
it's not.
There is some discoloration.
He's 82 years old. Everything is discolored.
So it's kind of interesting here. So when a patient comes in and you're trying to find a diagnosis, you have a differential diagnosis we talk about, which is what are the most likely causes of this patient's symptoms or problems. So here in Shaun's case, he's analyzing this, he's looking at the patient's wound, he sees a little discoloration, and he's starting to think about all kinds of things like, he said here, an infection of the wound. And obviously the nurse who's been there and seen lots and lots of different cases does not think this is an infection. And so we have a saying in medicine, when you hear hoofbeats, think horses and not zebras. What does that mean? So typically if someone has a symptom, you want to start off with the most common things first. So if there's some discoloration there, maybe it's just bruising and not necessarily an infection. And obviously the more experience you have, the more accurate you become in ordering your differential diagnosis and becoming a better physician. And so this is why it's important in training for patients to see lots and lots of patients. And this is why residency is so long and so grueling to go through, because really you're expected to see thousands and thousands of patients. Like when I first started in surgical residency, I clearly remember one of my chief residents saying, you need to look at every possible wound. When you're on rounds and you're changing dressings, you need to look at that wound. You need to ask your senior resident, is that an infection or not? And if you're not sure, you need to ask, and that's how you gain experience. And eventually, so now I just can look at a wound and I just kind of know that's infected or that's not, but it didn't start off that way. And so medical training is all about repeated experiences over and over through thousands of patients and gaining your experience, knowledge in that manner.
Tumors entirely encase the large abdominal arteries.
That's very bad. If it's in the artery walls, it's going to be impossible to cut out without killing her. You should get a biopsy to determine where the margins are.
Shaun here says that you should get a biopsy to determine where the margins are. So what does that mean? A biopsy is a sample of that tissue that they take in the operating room. They take it out and they send it to a pathologist who can look at that tissue under a microscope and determine, based on the cells that they see in the microscope, exactly what type of tumor that is. And the patient's still on the table and there's a pathologist on call that will analyze that slide during the surgery to give them an answer while the surgeon is still scrubbed in. So that's what's going on here. When he talks about getting a wide margin, what does that mean? So when you remove a tumor, you want to make sure that there is a cuff of normal tissue around that tumor. And so when he says you want to take biopsy to kind of obtain margins, what's going on is they're going to be taking tissues that are surrounding the tumor where they think that there's no tumor, and they'll look under the microscope for each of those biopsies and make sure that there's no tumor. And if there's tumor in that biopsy, then they need to take a wider margin of tissue to make sure that they get the tumor out cleanly.
Surgery isn't impossible, just very, very, very difficult.
Yes, in the sense that we'll be operating blind.
Yes, because the left kidney is in the way. She only needs one. Without the left one, it's theoretically possible to access the tumor and remove it.
You're suggesting we cut out a perfectly healthy organ just to get a better view?
Yes.
But she might die anyway.
Yes, quite probably.
So what's going on here is actually what we call preoperative surgical planning, where we're deciding what to do for the actual surgery. And this is actually harder than the actual surgery. And this is actually a common theme, it seems like, in this video, where in surgery, it's not just the surgery that we're thinking about or doing. There's so many other components to surgery, and this is a huge part of it. So before you actually go into the surgery, you want to be factoring everything in: the patient's anatomy, where the pathology is, what the goal of the surgery is, patient's medical comorbidities. These are just some of the factors. And how do these things work? If someone has some kind of blood vessel or nerve crossing where you want to access in surgery, you might not go that way. So, and also if a patient may be larger or the body habitus is larger, you may pick a different, what we call, approach. In spine surgery, instead of going from the front, anterior approach, you might go from the back, which is a posterior approach. And so these are all things you think about. If someone is also very sick, we call, or has lots of medical comorbidities, they may have a pacemaker, or they have a lot of cardiac issues, and it's risky to keep them under anesthesia for a long time, we may factor that in. And the plan for the surgery, we may take the shortest route or the quickest route to get what we need done.
Mayos?
Mayos.
Going to open the fascia and
So Mayo scissors are super critical. We use them in pretty much all types of surgery. I use them in my surgery, and they're what we call a dissecting tool, where you use them to get in between different muscles to open up what we call surgical planes to get to where we need to operate.
You clamp the renal hilum.
Clamp.
Clamp.
Just cut off the blood supply to a perfectly healthy kidney.
First of all, let's talk about what is a kidney. I didn't know what a kidney was before I went to medical school, to be honest. And a kidney is a vital set of organs that actually filters our blood. And by filtering the blood, you're taking out all the contaminants in it. I guess that's the simple way to think about it. And that's why you produce urine. Urine is also the waste products from the blood. The kidney is a filtration system. And he talked about here the renal hilum. So the renal hilum is actually where the blood vessels pass into the kidney. The renal artery and the vein kind of go in and out of the kidney, and the blood gets filtered in the kidney. And then the ureter is where the urine passes out, the urine that's produced, and that dumps into the bladder. And so that's what's being clamped here.
Oh, what the hell does that mean?
What does that mean, Shaun?
Am I healthy?
Probably.
You're a doctor. You're supposed to know.
No, we're not. Nobody knows anything for sure. Anybody could drop dead of a heart attack at any time.
Who is this guy? Am I gonna...
I mean, Shaun does have a point here. So nothing in medicine is certain. In spine surgery, everyone wants to know from me, if I have the surgery, am I going to get paralyzed? And, you know, I try to answer their question as honestly as possible, but also offer reassurance. But no one can tell anyone that, you know, you're definitely not going to get paralyzed from anything. In spine surgery, it's very, very rare. That risk is higher in certain surgeries, like when you're doing cervical surgery around the neck. That possibility is a lot higher than, let's say, you're working in the lumbar spine in the lower back. And so the analogy I kind of use with my patients is actually similar to what Shaun says. When someone asks me about paralysis, I say, well, you know, I can't tell you 100% sure, but it's kind of like getting hit by lightning. It's very, very rare. Is it possible? Sure. And so Shaun may be actually saying this pretty forcefully, but he's actually right.
Shaun, people need reassurance.
I told him he was safe to go home. I was very clear.
But with your words, your actions said something completely different.
No, they didn't. My actions were completely silent.
When you reassure someone, they have to receive it. You have to gauge whether they actually are reassured. You understand?
Dr. Glassman here has an excellent point, which is when you're speaking to a patient, you really have to assess how they're feeling in the situation. It's really a two-way street, and I think this is something I take very seriously. When you're communicating with a patient, you really want to assess how they're feeling. It's a two-way street. You kind of have to meet your patient halfway. You can't just kind of force information down their throat. You really want to assess whether they're processing the information you're giving them, their understanding, and also whether you said something might have rubbed them the wrong way or thrown them off. In doctoring, there's just a lot of sensitive situations, and I think this is something that it's hard to just learn right away in medical school, and it really comes through lots and lots of experience in residency, in your training, seeing thousands of patients. You can develop the skill to really be nurturing to the patient, also deliver good information and educate them. So Dr. Glassman has a really good point here.
Her pulse is too weak to perfuse her organs.
What? What is that? Jerry!
Please hurry.
What Shaun is doing is he's starting chest compressions in the car, and what he's really doing here is he took the pulse and he said the pulse is too weak, meaning her heart is not beating strongly enough to perfuse all of her organs. The blood's not getting everywhere it needs to. So he's helping her out by doing these chest compressions and basically artificially circulating the blood to perfuse her organs here.
Patient is a 10-year-old female. She has bradycardia with hypovolemic shock.
He said here that she has bradycardia with hypovolemic shock. So what is hypovolemic shock? That's a life-threatening condition where someone loses enough blood that they can't perfuse the rest of their body. So not enough blood to get everywhere in their body. And typically, it's not bradycardia like Shaun mentioned here. It's actually tachycardia. So the heart starts working a lot faster to try to get the blood where it needs to go. So I think this is an error, but who knows?
She needs oxygen, IV adrenaline, and a liter of saline. Wide open, please.
So here he said, I need oxygen, IV adrenaline, and a liter of saline run wide open. So what does that mean? The liter of saline is basically IV fluid that's run through a wide bore IV or a needle that's very, very wide, and that allows the IV fluids to get into her system very quickly because she has hypovolemic shock. She doesn't have enough fluid, and one way to resuscitate a patient or get their circulation up is to give them fluids very rapidly. Also, the IV adrenaline, also what that serves to do is it serves to constrict blood vessels and raise the blood pressure, which should help with the perfusion as well. He wants oxygen to be put on the patient and get the blood more oxygenated. The whole point of the blood is to, when it reaches the organs, it delivers oxygen. So that's critical as well.
Her pulse is better. She needs an ultrasound.
That is it.
think you got it all.
You think?
No, you definitely did. I just can't quite believe it.
It's your idea. You should have more confidence.
Nice work, Doctor.
So that scene honestly gives me a little chills because it's really all what surgery is all about. And it's so funny, this scene actually kind of brought me back to a situation like 2 weeks ago. Me and my partner, Dr. Basra, who I spoke about in one of my previous videos, had just done a pretty challenging lumbar fusion where we were working in a very small hole. We were manipulating nerves just a few millimeters. We were getting through the case, and eventually we successfully put the screws and rods in. Everything went well with the case, but it was something where we really had to work carefully, and we were kind of pushed to our limits. And we were eating our lunch afterwards, and I remember Dr. Basra made a comment. It's just so crazy, we're sitting here eating our lunch, no big deal. We just did this surgery. We were working in this deep hole, manipulating nerves, and we were working around someone's nerves, and now we're just sitting here eating our salads and our grilled cheese sandwich. And so it was just kind of striking to me that we are able to do these complex surgeries, and we treat it as a very routine thing. And I always kind of reassure my patients with this as well, saying like, look, everyone has their job, and for me, surgery is a normal thing. For you, this might be a once-in-a-lifetime experience, but for me, we do this every single day. We do these complex, challenging surgeries, and it's very routine to us. And so this scene was awesome in just seeing them accomplish something amazing in surgery, and that's the beauty of what we do.
Martine needs surgery immediately.
We need to confirm with Dr. Melendez.
No, Dr. Melendez is in surgery. Part of Martine's bowel is dying and killing her with it.
No, you cannot make these calls on your own.
It's past midnight, which means it's tomorrow, which means you're no longer my boss.
Ooh.
Is this the OR scheduler? Yes, this is Dr. Murphy. Prepare an OR for surgery.
So what Shaun is doing here, where he's calling the OR to prepare for a case, is pretty accurate in the sense that that's what surgeons do. We have, if there's what we call an add-on case. So an add-on case is a case that is not scheduled. It's usually like an emergent case, like here, where they have to rush a patient to the OR. You have to call the OR and let them know beforehand, and that usually involves a phone call that also, depending on the urgency of your case. So typically in spine surgery, we don't really run into too many super emergent cases where a patient is dying or anything like that. That would be a different story. Typically, if I have an urgent or emergent case, I would call the OR and ask them, hey, do you have room in the OR for my patient? What's the schedule look like? And sometimes the OR is a zoo. There's 4 cases going on. There's not enough nurses around, and everything is kind of triaged based on how emergent or urgent your case is. So if someone is bleeding out and they're about to die, obviously they will open up an OR for that patient and figure it out. This phone call definitely happens where you call the OR scheduler. This is why surgeons should be super nice to whoever's the triage nurse or whoever's a charge nurse in the operating room, the scheduler, because they kind of hold some power over whether your case goes in. And here you're also telling them your case needs. So I would tell them I need certain implants, I need this type of imaging system, I need an x-ray machine in the operating room. I'm gonna also need things like certain curettes or certain instruments. That's all being passed on during this phone call so they can set up for the case as well. And so calling up to the OR scheduler, this is very accurate and does happen in real care in the hospital.
10 blade?
I'll take it from here.
Oh.
Nice diagnosis. I'll handle the repair work. Back on suction. Congratulations.
Suction ready.
Woo!
So back on suction, Shaun is being given the assistant role, and I guess what you can think of is suctioning is like the scut of being in the surgery. It's not the glamorous part. You're not doing the actual surgery. What is suctioning? So when you're in the surgical field and you're working in the surgical field, there's going to be blood that's obscuring the surgeon's view, bleeding, and the suction helps keep some of the fluid and the blood out of the view so the surgeon can see what they're actually doing. Sometimes the surgeon will operate with one hand on the suction and one hand with an instrument, or sometimes their assistant will do the suctioning. Here, Shaun's doing this, the suctioning. It's not necessarily a glamorous part of surgery, but we had a saying in surgical training, which is, if you want to learn to be a good surgeon, you have to learn how to be a good assistant first. And so suctioning matters. And I remember as a medical student, I really wanted to kind of impress my attending, so I was really intense about my suctioning, just making sure that the field was completely dry, making sure, and it's not just that easy, just getting the blood. You want to stay out of the field of view of the surgeon himself or herself as well, where suction is not in their field of view, and you would get yelled at if your suction might obscure their view, so you want to be out of their view. And what this also takes is kind of knowing the steps of a surgery. So if you know the steps of a surgery, you can be a better assistant. And so this is why we have that saying, to be a good surgeon, you have to be a good assistant first.
Go on and take a bow. You've earned it.
Why does it matter who gets credit?
It matters because the people who get credit, they don't have to do scut work.
So I like Shaun's attitude here a lot. In medical training, it'd be nice is like, oh, you know, it's all about the patient, and you know, I don't really want to get credit for this. But what Dr. Glassman is saying here is that if you want to get credit so you don't have to do scut work, what he's really talking about is that as residents move up in training, you are showing that you are reliable, you are hardworking, and that you are going to be a very conscientious doctor. Do that through all these successful things like you're making a diagnosis or you're working up a patient, and your attendings will trust you more. And if your attendings trust you more, then obviously they'll let you operate more. And so that's his point of saying, look, you want to get credit so you can do less scut work.
Dr. Murphy, thank you so much.
Thank you.
All right, guys, so that's what being a doctor is all about. That's what it comes down to, the last hug with the patient. And honestly, this show is awesome in that, you know, being a doctor, honestly, obviously the drama, it's not as dramatic. You know, every day in the office is kind of the same thing. I see the same conditions. My surgeries are pretty routine. But, you know, this doesn't change, actually. I get lots of very grateful and appreciative patients who are so happy after I'm able to help them take away their pain. And to me, that is the best part about being a doctor. And it's kind of funny, watching the show kind of brings back some emotions because it reminds you about why we went into medicine in the first place. When it comes down to all the medical school essays or the residency essays I wrote, if you really went down to it, it was about this. It was about helping people, helping our patients, and that's why we became physicians and we became surgeons, because we wanted to do this. So in that sense, I really love this ending to the show. And this show, all in all, was amazing. You know, to be honest, in my medical school curriculum and residency, I didn't get much exposure to this condition, autism. Actually, by watching the show, I ended up looking it up. I went to, I think, autismspeaks.org, and I actually read up and learned more about this condition. And it's great that the show is raising awareness for this condition. And even myself, I think I'll be a better doctor for it. So I'm really looking forward to more episodes of The Good Doctor. I think that there's a lot of good medical dramas out there. I haven't watched medical shows in a long time, and I'm doing them more for YouTube now for you guys. And I'm really looking forward to this. So if you enjoyed this video, make sure you like the video, hit subscribe, and also down in the comments, let me know what show and what episode you'd like me to do next. Thanks so much, guys, for watching, and I'll see you on the next video.